All right, well, good morning, everyone. Again, it's a pleasure to start CVI 2017. Thank you all for coming. It's, as you know, it's the first year we do this meeting in Denver, and we're delighted to have some outstanding faculty. Let me start by introduce the panel, and we'll be doing some of the talks for this morning. Next to me is Dr. Anna Prasad from San Antonio, Mike Luna from UT Southwestern in Dallas, Tim Henry from Cedars-Sinai, and Mazen Abu-Fadel from University of Oklahoma. And the first speaker is going to be Dr. Houman Khalili about how to treat acute vessel enclosure. Just to say that Dr. Minh Vo had an issue with getting through customs. I don't know if it has to do with the new immigration policies, but he's going to make it a little late, so we'll have a little change in the program and we'll give his talk instead. And just to clarify, also Dr. Henry will be moderating the session with me this morning. So thanks again, and Houman, kick it off.
All right, thank you very much. All right, it's good to start this session with a topic that's near and dear to my heart, treating acute vessel closure. I got no disclosures. So we all know what acute vessel closure is. We've seen it. Let's put a definition to it. It's abrupt cessation of flow to TIMI grade 0-1 from a TIMI grade 2 or 3 prior to balloon angioplasty. The cessation of flow has to occur proximal or less than or equal to 5 millimeters distal to the target lesion. Other conditions that could meet the criteria are having a TIMI grade 1 at the beginning and going to a grade TIMI 0, no flow, or starting with TIMI 0 with no flow, getting some flow back, TIMI 2 or 3 down the coronary vessel, and then going back to TIMI 0 or 1 with additional therapy during the procedure. There are two qualifier terms, sustain and transient as well. The sustain, of course, is if there's a failure to establish a flow in the coronary at the time of the cath lab discharge despite all therapeutic measures, and transient, which is restoration of blood flow prior to cath lab discharge. So what are the major causes of acute vessel closure? Again, most of us are familiar with these. Is this section, the trauma to the intimal layer of the vessel due to balloon angioplasty can open up a flap and cause occlusion of the blood vessel. That can be accompanied with intramural hematoma, collection of blood underneath that layer. Intramural hematoma of note can also, of course, occur separately as a separate entity without a visible dissection flap. Thrombosis, this can happen in the setting of either just acute stent thrombosis, a fresh stent that was just implanted, or just trauma to the plaque can cause opening up a lot of atherogenic thrombi and cause occlusion of vessel. In the setting of a non-therapeutic, antithrombotic, or therapeutic. No reflow, I'm not going to go into it that much because one of the following talks is going to be about that, but no reflow can occur due to desembolization of the atherosclerotic plaque distally, and you'll end up with no reflow. Spasm is rare to have spasm as the only culprit just for the acute vessel closure, but it's definitely a contributing factor to acute vessel closure along with dissection, thrombosis, or no reflow. And side branch occlusion, of course, main vessel stenting, you can cause carina shift or plaque shift, and that could end up resulting in side branch occlusion. And air embolism due to accidental introduction of air bubbles down the coronary bed. Oops. So how common is permanent AVC? Of course, this was a lot more common in the pre-stent era, about 3%, but nowadays it's 0.3% in the stent era. The rate of transient AVC is likely to be higher. But why is transient AVC important? Well, transient AVC or permanent AVC, either one of them portend a high risk of major ischemic events. In this study from Piana et al. In JACC 1999, it was one of the strongest predictors of major ischemic events when compared to other clinical lesion characteristics. What are the predictors of acute vessel closure? There are two broad categories, clinical and angiographic. Clinical, acute MI, you have a high thrombus burden. You can get a lot of thrombus that embolize down the vessel. Cardiogenic shock, advanced age, female gender, and diabetes, a high risk for dissection. And diabetes, renal disease, of course, with a lot of diffuse multivessel disease. Angiographic characteristics that are predictors of AVC include baseline thrombus, again, high risk for disembolization, multivessel disease, bifurcation lesions and angular lesions, a high risk for side branch occlusion. I won't get a whole lot in detail of the side branch occlusion in this talk. Long lesions, tortuous vessel, increased risk for dissection, Old venous graft, increased risk for distal embolization, and same for atherectomy, increased risk for distal embolization. So how to manage it? Two broad ways that we need to address, two broad categories. Managing hemodynamics and ischemia, recognizing the mechanism of acute vessel closure and restoring flow. We've seen acute vessel closure in the cath lab. Main complaints that patients have is typically start having chest pain, just shortness of breath, nausea, just not feeling overall comfortable. You look at the monitor, patient's hypertensive, potentially bradycardic. You may or may not see ischemic changes on the monitor as well. So it's important to address both of those. And it's important to address the patient's symptoms of ischemia, of chest discomfort. Important to address the hemodynamics because that blood pressure, if it's hypertensive, that could easily spiral down. And you could end up, depending on the myocardium that's subtended by that coronary artery, you could end up having PA arrest as well. So addressing the hemodynamics and ischemia, and again, IV fluid resuscitations to bring the blood pressure up, pressors and inotropes if that's needed, atropine for bradycardia, and or a temporary pacemaker if that's needed. Percutaneous assist device, the Impella balloon pump if the hemodynamics continues to be unstable and despite the IV fluids, despite the chemical measures that are taken, anti-anginal medication, analgesics to make the patient begin, to relieve the pain, and antiemetics if that's what's needed also. As far as recognizing mechanism and restore flow, I think regardless of what the mechanism is, nitroglycerin is important to administer intracoronary because, again, spasm, even though it may not be the only, the rare cause of acute vessel closure, but it's definitely a contributing factor. So intracoronary nitroglycerin or other vasodilator needs to be administered initially. Check the anticoagulation time, make sure that it is in the therapeutic range, and balloon angioplasty. Whether it's a thrombus, whether it's a dissection plant, the dissection flap, balloon angioplasty may help open up some sort of channel, something to get the blood flow going down in the coronary. And then repeat the angiography, see what's going on, and then determine the etiology potentially. If you do the angiography and you see there's established a blood flow, you can consider stenting, grade, just procedure PCI. If there is a visible thrombus, you can consider repeat balloon inflation, aspiration thrombectomy, and even injection of intracoronary vasodilators. You can consider using a microcatheter for injection of intracoronary vasodilators, using the same aspiration catheter, of course, after the discard of the thrombus, get down the vessel and deliver the vasodilators at the target zone. Glycoprotein 2B3 inhibitors would be helpful for additional antiplatelet therapy. Dissection, if you see a flap, consider stenting. I think most people would consider stenting nowadays in a case of a flap that causes acute vessel closure. No reflow. Again, I won't go into too much detail of that, but intracoronary nitroprusside, verapamil, adenosine, have all three of them been found to be helpful. Again, you can also consider a microcatheter for delivery, local directed therapy, and delivery of these drugs, as I mentioned before. And spasm, intracoronary nitroglycerin, and consider, again, verapamil. If there's no clear etiology that's identified, change angiographic projections, change the view to some orthogonal view, something other than your working view. You may be able to unmask a dissection flap. You may be able to unmask a thrombus you didn't see earlier. Intravascular ultrasound could be extremely helpful to see a dissection, see an intramural hematoma, or a thrombus that you didn't see previously. Distal contrast injection can be very helpful in differentiating between a lesion pathology versus no reflow. If you, again, use the same catheter to get distal to a lesion, inject contrast, and see if there's flow. If there's flow, brisk flow downstream, it's probably not a no reflow situation. It's probably something going on in the lesion, either a dissection or a thrombus. And, of course, consider air embolism if there's the involvement of a different branch. So I have three cases. This patient came in with unstable angina symptoms, had mid-LAD lesion, just happened to have Neer's IVUS performed, which showed high lipid core plaque burden in the middle of the LAD. We proceeded with stenting, two stents, one long, one short, one replaced, and this is the immediate angiography following that, showing no flow. So knowing having the knowledge of the Neer's study, with a high lipid plaque burden, we felt like this is most likely due to, and the to and fro pattern that you see of the contrast within the middle AD, we felt like this was most likely due to distal embolization. So again, going down the protocol, we administer IC nitroprusside, plenty of that. Balloon dilation was also performed. Now, adenosine had to be also administered for additional vasodilator therapy. 2B3s were instituted after 5 to 10 minutes we were able to establish flow down the coronary. Another case, patient comes in with stable angina, had 2 vessel coronary artery disease, has a first diagonal artery stenosis as well as the RCA CTO. We proceeded with stenting the diagonal first, placed 1 stent there, and this is what we got, no flow. And patient started experiencing chest pain, some lateral ischemic changes on the EKG. We gave IC nitroglycerin, balloon dilation, no change. So we proceeded grabbing all the IVUS and did a quick pullback, and this is what we saw. So you can see a collection of blood underneath there. It's an intramural hematoma. So we went ahead and we trapped that hematoma, placed a stent distally to trap the hematoma from propagating further, and placed a overlapping stent in the middle. And there's a follow-up angiography after that. Symptoms went away, hemodynamics stable, EKG changes resolved. This is a kind of an ugly case. Radial case, patient comes in with stable angina, severe first obtuse margin stenosis, heavily calcified. Predilation was performed, tried to deliver a stent. The goal was to deliver a stent, the circ to the OM, and heavily dissected all the way through. Again, I don't think there is any enigma as far as diagnosis goes. Dissection, again, we got the femoral access here, use a ping pong technique. We're able to successfully wire through all the dissection flap into the OM, the circumflex and the LAD were wired. And the T-stent mini crush was performed. There's still residual dissection, but now we've got TIMI flow, TIMI 3 flow, TIMI 2-3 flow downstream. Patient was feeling better, no ischemic changes, hemodynamics were stable, and so we ended up with that. All right. That's all.
Okay, thank you, Houman. That was a great case. Any questions from the panel? So I think the main thing is here that you know the mechanism, right? If it closes, is it embolization? Is it dissection? What is the problem? And then you can take care of it. And using IVUS can be very, very helpful. So thank you very much. That was a great presentation.